Now, for this skill, what you'll want to do is you'll want to provide privacy to the patient, wash your hands, and tell them what you are doing to assess visual acuity using a Snellen chart. And what you're going to do is you're going to have your patient stand about 20 feet from the chart. So Ben, if you'll stand about right there for me, and ask your patient, do you wear glasses?
No.
Okay, and if your patient does wear glasses, you'll want them to wear those for this test. Okay, so what we're gonna do, look at that chart over there and try to read the lowest line for me that you can read, okay? And first we're gonna cover your right eye, then your left eye, and then we'll do both eyes, okay? So cover your right eye. Okay, and what line can you read?
8.
Okay, read it for me.
D, E, F, P, O, T, E, C.
Okay, very good. Okay, now we're going to cover up your left eye and do the same thing. And again, whatever line you can read, let me know.
8.
8 again, okay.
D, E, F, P, O, T, E, C.
Okay, and now read with both eyes. And what line?
8.
Okay.
D, E, F, P, O, T, E, C.
Okay, and he read from line 8, so that means that he has 20/20 vision. And this means that he can see the same line of letters at 20 feet that a person with normal vision can see at 20 feet. However, let's say that in his left eye, he could only read like line 6, which is 20/30. That would mean that his left eye sees at 20 feet that a person with normal vision would see at 30. Okay.
You can test visual acuity with a near vision card, but it is not nearly as accurate as using the Snellen distance acuity chart because it is easy to misestimate the proper testing distance. The near vision card contains letters or numbers that are scaled down for testing at a distance of 14 inches or 36 centimeters from the eyes. Position the near card at the correct distance. Be sure the patient is wearing glasses normally used for reading. Test one eye at a time. If the patient is using glasses, use a tissue to block the vision in one eye in order to avoid smearing the glasses. Instruct the patient to read the smallest line on which he can identify the numbers. The fraction located at the right of the line provides the visual acuity score. Record near visual acuity using the Snellen notation just as you would for testing distance vision. Give the patient credit for the line on which all numbers are correctly identified. To screen for gross visual field defects, ask the patient to identify fingers displayed first before one eye, then before the other.
1, 2, 1, 1, 2, 1, 1, 2, 1, 3, 1, 3, 1, 2, 3, 4.
Suppose the patient cannot see any fingers displayed in a hemifield. Here's what you should do. How many?
1, 2, 2, 1.
Tell me when you first see my finger by saying the word now.
Now. Now.
To conduct a corneal light reflex, you'll need a pen light and a patient. You'll ask your patient to stare off in the distance or focus on something at least 15 feet away. With this test, the corneal light reflex test, you're testing for ocular alignment by reflecting your pen light off the patient's pupils. You're looking for esotropia, exotropia, hypertropia, or hypotropia. Really, this means you're looking for uneven gaze in the two eyes. Your two eyes should be able to focus on something relatively similarly. You want to hold your pen light about 2 feet away from your patient's eyes and shine it equally into both, so right along the midline. When you shine it, you're looking for the actual reflection, the pinpoint reflection of the light in the patient's pupils. This light, as long as it's held medially and about 2 feet away, should be in the exact same location in the patient's two pupils, meaning that when looking at the patient's pupils, you'll see a little point, just a little pinpoint of light coming from your pen light in relatively the exact same spot. I'll conduct the test now. Here you can see that my pen light is showing up very clearly in the pupils, in both pupils of the patient in relatively the same spot, on that medial upper aspect of the pupil. This means that the test is negative for any sort of dissymmetry in the gaze or between the two pupils of the patient.
Have the patient look directly at a target at least 10 feet away. Cover the left eye and watch for a movement of the uncovered eye. Repeat this step a few times. Then do exactly the same thing in covering the right eye. If no movement occurs in the uncovered eye, the eyes are aligned. Here is a patient with esotropia. The left eye is deviated inward. As the fixating right eye is covered, the left eye moves outward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye. Here is a patient with exotropia. The left eye is deviated outward. As the fixating right eye is covered, the left eye moves inward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye. Here is a patient with a left hypertropia. The left eye is deviated upward. As the fixating eye is covered, the deviated left eye moves downward to pick up fixation. As the non-fixating left eye is covered, there is no movement of the already fixating right eye.
I'm going to demonstrate how to assess the 6 cardinal fields of gaze. Now, why do we assess the 6 cardinal fields of gaze? Well, it tells us how well those extraocular muscles of the eyes are working, and there's 6 of them. We're assessing the superior rectus muscle, which helps us with upward movement of the eye, the superior oblique, which helps with downward and outward movement of the eye, lateral rectus, which helps with outward movement, medial rectus, which helps with inward movement, inferior oblique, which helps with upward and outward movement, and lastly, the inferior rectus, which helps with downward movement. And when we're performing this skill, we're going to have the patient move their eyes in the following directions. In the right upper part, the left lower, the left upper, the right lower, and then left to right. And while the patient is doing this, we are looking for a smooth motion of the eye, which would be a normal finding. We would not want the eyes to jerk or to shake as they move, and if they did, that would be known as nystagmus. And how we're going to do that is we're going to take our pen light, we're going to hold it about 12 to 14 inches away from the patient's nose. And Ben, what I want you to do is keep your head still, don't move your head, and just use your eyes to watch where I move the pen light. And as you're doing this, you're going to perform it in the 6 cardinal fields of gaze, and you're just going to move it and you're looking for any involuntary shaking of the eyes. So here we go. To inspect the eyes first, and we're looking at several things. We're looking at the eyelid, we're looking at the sclera, which is the white of the eyes, we're looking at the iris, we're looking at the pupil, and we're looking at the conjunctiva. So you shouldn't see any swelling of the eyelids. You should see that the sclera is white and shiny. It shouldn't be yellow like in jaundice. And the conjunctiva, when you pull down the lower lid, have the patient look up, it should be nice and pink. It shouldn't be red. You shouldn't see any drainage or anything like that. Then look at the eyes. How do they set in the eye socket? Are they equal? For instance, is there any strabismus? Is there a cross eye where one eye turns in more, turns out or up or down? And these eyes are normal. There's no strabismus. Next, you want to look at anisocoria, where one pupil would be smaller than the other pupil. Are they equal in size? Normal pupils should be 3 to 5 millimeters in their measurement, and here his are about a 3, and they are equal.
Eversion of the upper eyelid is mandatory in order to examine the upper palpebral conjunctiva. This can be performed with practice with your fingers alone. A cotton tip applicator can also be used. The applicator is placed in the sulcus of the upper eyelid and the lashes are grasped and everted over the applicator.
Inspect and palpate the lacrimal gland, lacrimal sac, and the nasolacrimal duct.
Regurgitation on pressure over the lacrimal sac, or the Roplass test. We start by palpating the inferior orbital rim and proceed medially till we reach the medial canthus. Following this, we rotate our finger inwards, pushing the medial canthus inwards. We look for any discharge from the punctum. Absence of any discharge indicates a normal nasolacrimal duct. A positive Roplass test. We palpate the inferior orbital rim and proceed nasally till we reach the medial canthus and then press inwards. A mucoid discharge or fluid regurgitating from the punctum indicates a blocked nasolacrimal duct, which is a positive Roplass test.
Inspect the cornea for clarity and texture. Ask the client to look straight ahead, hold the pen light at an oblique angle to the eye, and move the light slowly across the corneal surface.
Next, we're going to see how reactive the pupils are to light. And to do that, we're going to dim the lights a little bit and we're going to have the patient stare off at a distant object that helps dilate those pupils. And then we're going to shine using our pen light in at the side and we're going to see how that pupil responds. It should constrict, and then on the other side it should constrict as well. So say their baseline pupil size was like 3 millimeters, it should go down to 1 millimeter, and it should happen on both sides. Okay, so Ben, stare off at that object right on the wall over there for me. Okay, and that dilates the pupils, and we're just going to shine light in at this side. Okay, constrict, constrict. Okay, let them dilate again, and then go to the other side, do the same again. And they both constricted in equal size. Next, what we're going to do is we're going to check for accommodation, and how we do that is we turn the lights back on. We just previously had them dim, but we now make it light again. We're going to have him stare off at a distant object that helps dilate the pupils, and we're going to take a pen light. You can use a pen light finger, and you're just going to slowly move it inward to the nose. And what you're looking for is that those pupils constrict, they accommodate, and the eyes cross while looking at the pen light. So here we go. Stare off in the distance, please, and I don't want you to move your head or anything, just keep it real still and just follow this pen light, okay? Ready? Okay, so now we can document, because we just checked all of the things with the eyes, we can document that the pupils are equal, round, reactive to light, and the accommodate. So that's where that acronym PERRLA comes into play.